Are we live?
Hi there. I'm guessing we're live. So I can't, a little different this time, but welcome Facebook Live folks who are watching us and those who are going to be watching us not live. Thanks for popping in and joining us. I'm Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. And we're going to talk today about diabetes. And this is part of our Growing Healthy series. And I'm going to have Sherry DeWalt talk a little bit more about that and talk about our person that I'm going to be interviewing. So Sherry?
Okay, thank you. Thanks, Dr. Bird. Yes, so the CGH Health Foundation has been doing these Growing Healthier programs for several years, and every month we have a speaker. And November is Diabetes Awareness Month. And of our practitioners, I think Dr. Blazquez, who is our speaker this month, is one of those who just knows a lot about treating diabetes. The title of his program this month is Thriving with Diabetes, and he's going to be talking about some of the things that you can do to manage your diabetes better. We don't do a program typically in December, and we're working on our programs for next year, January, February, March. So if you have any ideas for topics, things that you would like us to cover or providers that you would like to see featured, please just leave us some comments and we'll try to get those scheduled. The other thing I want to remind you of is that all of our Growing Healthier programs are available at the CGH website on our YouTube channel. So if there's one that you missed or you want to see it again, all you have to do is go to the CGH website and click on the YouTube icon there. And I'm going to go ahead and turn it back to Dr. Bird, and he'll have his conversation with Dr. Blazquez.
Thanks, Sherry. Hey, Dr. Blazquez, good to see you.
Hi, nice to see you. Thank you for having me here.
Oh, yeah. Thank you for being halved.
Oh, thank you. It's a nice day to be out there, though.
Yeah, I hear you. So, and for the folks who are watching, we're going to talk about diabetes with Dr. Blazquez, and then when we get done with that, then we'll give you some COVID stuff that's going on here at the hospital, just give you some updates. So, good. So, Dr. Blazquez, you've been at the CGH for a little while now, haven't you?
Yes, I've been here for, I think we're going into 27 years now.
Ooh,
27,
wow.
28 years. So I came straight out of my training here.
You were like a teenager when you came here.
Yes, it's been good. It's been good. It's been a long haul, but it's been good.
All right, good. So hey, let's get into this. So you're a family practice doc.
Correct.
Obviously, you have some special interest in diabetes. What got you interested in kind of going deeper into diabetes?
Without trying to make it too long here, when I was training in family practice, I believe it was on my second year, in the hospital that I trained at, St. Mary of Nazareth in Chicago area, we had one floor dedicated just for diabetes. So we had a lot of diabetics there. And I came attached to this girl who was 12 from a dysfunctional family. She was diabetic 12 from a dysfunctional family. And I made it my mission to try to get her better. It ends up with a sad story because it was a dysfunctional family. And unfortunately, because of being dysfunctional, at one point she couldn't get her insulin. And she ended up expiring in one of those admissions later on.
Wow.
And it broke my heart that this patient died. And yes, it was the diabetes who killed her, but it was also the dysfunctional part. And that's when I realized that we had to be more aggressive, not only on treatment, but also on the whole big picture of treating the diabetes. So then I decided to do most of my optional rotations and elective rotations in diabetes.
Okay.
And I became the protege of our diabetic professor in the place. And I've been interested ever since.
Yeah, well, that's a story that makes sense to me. Yeah. So that's great. Not great, that story, but great that, it kind of spurs you on to have this interest. So I want to get into some of your expertise about this, Angel. So what first of all, like, just for folks, what's the definition like from a laboratory standpoint of diabetes?
Yeah, so the definition has changed through the years, and it has become more and more strict, which is good because we can detect more people and early on. But we have the definition for diabetes and prediabetes, and we base that nowadays mostly on something called hemoglobin A1C. And hemoglobin A1C gives you an idea how is your average blood sugar over the last 90 days.
Okay.
And it has to do with red blood cells that have this glucose attached to the red blood cells and the percentage of those cells that have the glucose attached to it. So it's called glycosylated hemoglobin. So we have parameters, and normal people are below 5.7 on this hemoglobin A1C. If you are between 5.7 and 6.4, you're then considered pre-diabetic or increased risk of diabetes. Okay. If you have a 6.5 or higher, then you're considered diabetic. But we can also use fasting blood sugar, in which you check the sugar in the morning, and if it's been more than 125 2 consecutive times, that is enough to say that you are diabetic. On the same token, we use blood sugar between 100 and 124 for a fasting blood sugar. That puts you into the window of being pre-diabetic. But again, we like to confirm with the hemoglobin A1C to get the picture.
And then is there, if I remember right, there's a if your random blood sugar is above a certain number, does that also make you diabetic?
Yes, if your random blood sugar is above 200, then that puts you into that category.
So if you've had a Coke or something like that, we just spot check your blood sugar. You shouldn't be above 200. If you're
shouldn't get there. Most people, normal people don't get above 140. Between 140 and 200, you could be in that pre-diabetes. But more than 200, you're probably diabetic. Yeah. Again, we verify with the hemoglobin A1C because there's only so much glucose our body can handle before it goes up on your blood. Even if you're normal, there's only so much you can handle. So if you go and have an ice cream with a Coke and you load your body, I mean, a normal person could, so a normal person could cross the line in those circumstances.
Okay. So one of the things that always comes up is how helpful is diet and or exercise in the management and or prevention of diabetes?
It's very important. We do know that most patients are type 2 diabetics, and type 2 diabetes is the one that most people get as an adult. And the triggering factor almost always is obesity, being overweight. You have to have the genetics for that, but the triggering factor is obesity. So diet is very important because that's what pushes you over the edge. And on the other token, if you have diabetes and you make lifetime modification and you lose about 5 to 7% of your body weight, that might be enough to get you out of diabetes or pre-diabetes. Okay. So it is extremely important.
And it's not crazy. I mean, so you're talking if you weigh 200 pounds and you get down to 185 to 190, that could be very helpful.
That might be enough to make a big difference. So it doesn't take a lot to get you out of that situation. But it takes the effort, it takes the effort. It's easier said than done.
Oh, don't we? Yeah. We've had enough patients to know and for ourselves even, it's just an ongoing battle. So, Okay. So good. So assuming that you have a patient who's done all they can do in terms of diet, exercise, all that kind of stuff. And I'm talking more now in this, our question is more about type 2 diabetics rather than the juvenile diabetics.
Yes.
What medicine do you usually start those patients on, and why do you usually start them on that medication?
The treatment for diabetes changed drastically just 2 years ago, and we typically start with something called metformin. Metformin has been around for over 20 years. It has been studied a lot, and I would like to mention here because some people are now thinking that metformin can cause cancer. So I would like to. There's so many people taking it that I would like to bring this out there. The scandal about metformin causing cancer was not the medication by itself. It was a contaminant on the pills, specifically for the extended release pill made in China, and they have some contaminants, but the medication doesn't cause cancer.
Yeah.
But we start with metformin, and then for metformin, we have a new algorithm of where to go with diabetes. And you may have patients going to different providers and suggesting different ways to treat diabetes because of all the options we have.
Yeah, let's talk about that. And by the way, on that metformin, I just saw a headline about that yesterday, Angel, and I think it was the dose that they were concerned about was a 750 milligram extended release dose. So it was just a particular dose, which
correct.
Just so folks are aware of that.
And again, to make it clear, it's not the chemical, it's not the medication, it's the bulking agents they use on the medication.
Yeah. Okay, good. So let's go. So the standard answer is metformin.
Correct.
So someone has diabetes, typically it's metformin. And metformin is inexpensive?
Metformin is very inexpensive. Metformin has been in the $5 formulary in many of the pharmacies and in big chains for quite some time. So it's very affordable medication.
Yeah, and if I remember right, it also helps you lose weight.
Yes, it helps you to lose weight.
A tendency towards that.
It kills your appetite a little bit, not much, but it helps your appetite. It helps you to lose weight. It has some side effects. Some people get loose stools, but not too often. If you start low and bring it up slow, usually it's not a problem.
Yeah. Okay. Yeah. So metformin is numero uno just from a cost, and we know it works, kind of effective. So let's go different directions though. So how about what's the latest on when we might not use metformin? Categories would be like someone has a history of heart disease or heart failure. What's the latest?
Yeah. So just for people to understand, what we do nowadays is when we evaluate a patient for diabetes, we don't look only at the fact that you're diabetic. Now we're looking at the fact, how is your kidney function? Do you have heart disease? Are you obese? Do you have overweight? And look at all those factors. And depending on the risk factors on people, we decide to go one way or the other one. On people with minimal risk factors, we can stay with some of the medications that have been around for a while, like Actos has been around for a while. It's now available in generic. And the GLP-1s and all that. These medications are still brand name. They're very safe to use, but they don't have a significant impact on heart disease and weight. But lately what we do is we look at the risk factors. And if somebody is having obesity or heart disease, now we typically try to go into two groups that are called SGLT2 and GLP-1. And both of those, most people have seen a lot of advertising on TV. The GLP-1s, most of them are injectable. So they're injectable medications, and now they have formulations that are once.
Like what kind of name? Rattle off some brand names of those.
Those would be your Bydureon, Ozempic, Trulicity, Byetta, Victoza. Victoza is daily, Byetta is daily.
Yeah, just so folks might be taking those or know what you're talking about. Right.
And these medications have been proven to reduce cardiovascular risk now. Most of the studies are showing about 12% reduction of cardiovascular risk.
Okay.
And they also induce weight loss. And even though the average weight loss is into the tens of pounds, we see patients that can lose 20, 30, 40 pounds. We've seen significant weight loss with this medication. And as the weight loss comes around, the diabetes gets better. And some people who are taking multiple other medications or even insulin, you see a reduction on the insulin dose. You see people who actually stop using insulin altogether when they lose significant weight. Then you're reducing the cardiovascular risk by at least 12%. So it's a win-win. They are expensive.
Yeah, I say, except the one thing who also wins is the drug company in terms of the cost.
Correct. So, they are.
How much does it cost, and how do what ballpark are we talking about?
There are brand new medications, and most of those are in the $600 a month range for those medications, $600 or more. Of course, with insurance can go a lot lower, but some people don't have insurance. And some insurance companies make it very difficult because they want to spend that money. But we have tools now. We can use cardiovascular disease. And now it is standard of care that if somebody's having documented cardiovascular disease, that's the way we should go. So we have tools to put pressure on the insurance companies to provide for this medication.
Yeah, so you have to fill something out, the kind of a pre-auth kind of thing.
We have to do this.
This is why.
And it is doable. It is doable. It takes a bit of work, but we have many cases that we succeeded by convincing these insurance companies that by covering this medication, they might be saving on heart disease later on, which is significant.
Yeah. Well, how about the other category? There's another you were talking about.
And the other one is called, the group is called SGLT2. And these medications are all oral medications. And I didn't say much about how the other one works, but I'll mention this one and then I'll go back to the other one. So these medications, the way they work, we have a normal mechanism in the kidneys that you're losing urine at one portion of the kidney. You're losing sugar at one portion of the kidney. And the kidney will reabsorb this sugar. And we have enzymes that are in charge of reabsorbing the sugar. So the one that they isolated is SGLT2, this SGLT1 and 2, and the one that is a stable molecule they can produce. And by taking this medication, it blocks the reabsorption of the glucose in the kidney. So
Okay.
you lose sugar in the urine. And by losing sugar in the urine, you lower your blood sugar.
Oh, there
And
you
it
go.
doesn't take a lot of loss in the kidneys to reduce your blood sugar. So these medications work excellent because they also reduce the cardiovascular risk. Um, they reduce readmissions for heart failure, and they reduce initial episodes of heart failure because they also have a diuretic effect. They make you lose water also. So by
Okay.
losing water, it helps with heart failure.
Yeah,
too.
that makes sense. Sure.
Yeah,
Sure.
it helps with that.
Okay.
So these medications are also expensive. They're also brand name, and
What are the
but
brand?
again,
What are the brand names that folks are
so
like?
some of the brand names is like Jardiance, Invocana, um, Sticlatro. I
This
sometimes
Farxiga one?
pronounce like in Italia, Farziga. Those are the main ones,
Yeah.
and they're all in the same price range. Again, they're all in the $600 plus for the
Okay.
medication.
Yeah.
Most of these drug companies have vouchers that if you have an insurance, they help with the deductible and they help with the copay. But if you're Medicare, those don't work.
Yeah.
And being that I mentioned how this one works, I would like to go back to the GLP-1s and also mention how those work. And the GLP-1s are the medications that I mentioned, the injectables. And these medications actually work on the other hormone that we have in the body. We have glucagon. And the problem with the glucagon is that the glucagon actually brings blood sugar up. So these medications help to reduce the glucagon, help to increase the insulin on the body. They also reduce the absorption of sugar in the stomach. So they delay the absorption of sugar in the stomach. And normally our liver stores glucose. And when we're out there, our liver is releasing this glucose into the bloodstream. So these medications also slow down
Okay.
this release of the glucose into the bloodstream, which is something we normally do when we start eating. We normally do that, and these medications work on that. So they have all these advantages.
Yeah. That's about. It's hitting a lot of different areas when it's doing that. Then. Yeah. Good. So. What I want to do next, though, is transition into sometimes you try those kind of medications, or in addition to these medications, we have to go down the path of insulin.
Yes.
And so when do you tend to put patients on insulin, Angel? And is there a type of insulin that you usually use, once again, for type 2 diabetics for those patients?
Yes. Let's put it first out there that insulin always works. You know, insulin is the hormone that lowers your blood sugar. So whenever you get frustrated that nothing else is working, insulin always works. You know, some people require more than others, but it always works. On type 1 patients, as we know, you have to use insulin. You have an option because they don't produce insulin. On type 2 patients, by the time you diagnose somebody as having type 2, their insulin production is down by usually half. You know, they have half the insulin production. And by working on these other medications, you can get by with this half. But sometimes it's just not enough because they have destroyed more than half of the insulin production in the body. And these medications don't get you there. You know, you get close, but you don't quite get there.
Yeah.
In those cases, you have no choice but to go into insulin. Otherwise, you'll never achieve good control. The other one is sometimes by using insulin, you can reduce costs because now using only one medication and not using all these other ones. Because all the ones that I mentioned, you can use in conjunction. And we usually end up using 2, 3, or 4 medications to control the blood sugar.
Yeah.
Some of those are $600 per
I'm doing the math on that, and that can be kind of pricey.
Yes. Yeah, we're talking about thousands, you know, over $1,000 per month. And if you go into insulin, the newer insulins are expensive, but there are also some older insulins out there. But when you add it up, it's not going to be as expensive as taking 3 brand name medications that are $600 each.
Yeah.
Also, something to keep in mind, and sometimes people, including us providers, don't think about this, is that some of these type 2 patients get older and the insulin production keeps going down. Then we have to be vigilant to make sure that we don't keep pushing medications, not knowing that they might be down to 10% production of insulin, and they might get down to 0. And we have a way of measuring the insulin on the body that is called C-peptide. So whenever I have somebody that I'm treating with medications and the medications don't seem to be working well, especially if this person is not an obese person, it's more common in non-obese people, we do a C-peptide, and I have seen several cases of people who are in the 70s and 80s, and they just don't have any insulin anymore.
Mm.
And they only respond to insulin. You have to treat them like a type 1 because
Yeah.
chemically they are a type 1, and that's
Yeah.
the only option. So on the insulins, you ask also about which insulins do we use nowadays.
Yeah.
And we have, we have great long-acting insulins nowadays. And it started many years ago with the Lantus, and the same company created the Solostar, and then they came with Trulicity Tresiba. And we're getting longer and longer insulins. So the insulins we have now available, you get an injection of insulin, and it lasts over 24 hours. So this will cover your basal needs. Now, of course, you have to do something about the blood sugar when you eat. So it's either you do a short-acting insulin at that time, or sometimes you do a combination of insulin and some of the medications that I mentioned.
Yeah.
And the combination works too.
Yeah.
There is the old insulin, the N and the R that we used when I started my practice. That's all we had.
Yeah.
And they still exist. And they are very inexpensive. I hardly ever use those because usually we can manage to find a way to cover for the long-acting insulin through programs, vouchers, and different things. But when we have no choice, or somebody's paying cash and there's no other choice, and they don't qualify for help from the companies, then you can use this long-acting, this medium-acting insulin is the N. And the N, you have to do 2 shots per day. That's the problem. So you have to do 2 shots per day, but it is doable. It's the way we treated with insulin for many years, and it worked in those days.
It's been a while, but it seems like it was a year or so ago I read a study where they were talking about that, and there's a convenience factor of doing the daily stuff. I remember right there, the study was saying, though, if you did the twice-a-day stuff, you end up about the same spot in terms of your control and how your blood sugars were. And is that right? I mean,
yes. And like I said, that's the way we did it for many years. And we would take the insulin, the N, and typically we use 2/3 of the dose in the morning, 1/3 in the evening. And then we also added some regular or fast-acting insulin for the meals.
Yeah.
And it worked pretty well. And we were achieving similar hemoglobin A1Cs as we achieve now. But the only difference is that you have to be very vigilant of low blood sugars during the night because they tend to peak more. So you have to be aware that you might get a low blood sugar at 3 p.m. or you might get a low blood sugar at 3 a.m. So then we have to be vigilant about those. But it is doable. We did it for years.
Yeah.
It just takes more control of the diet. You have to be better on the diet. So the newer insulins give you more freedom of.
I guess if you're paying out of your own pocket entirely, that might be something worth talking about with your doc.
Correct. That's the way to go. If you have to pay for it, that's the least expensive insulin out there.
Yeah. Okay. All right. So I'm going to segue to another thing related to insulin, and that is the pumps, the insulin pumps, which is something that's kind of in your career, I know, is kind of taken off. So when do you recommend, who are the patients that are the best candidates to be on pumps rather than on insulin shots or those type of things?
So number one is the type 1 patients, the young patients. So the type 1 patients have to be on insulin, and the insulin needs change hour per hour depending on the activity and the diet. And for those patients, insulin pump is the way to go. To treat type 1 other than insulin pump is pretty much a compromise. Sometimes you have to compromise, but the gold standard should be pumps. Not all of them are on pumps, but that should be the gold standard. On the type 2 patients, again, when I mentioned it, that some of these patients, the insulin production is going down.
Yeah.
You have to go into insulin. The insulin pump is the way to go if you can afford it. They are more expensive, but it is doable. And so most insurance companies cover for pumps if we can prove that they don't have enough insulin production. The other one is people who are very active and they can get by with the insulin doses they're using, the long-acting and the multiple shots per day, and they can be doing shots. Good example will be healthcare providers. If you're a healthcare provider and you work in an emergency room, you can't be stopping every time you get a snack and then get an insulin shot and go and check your blood sugar. And an insulin pump is the way to go.
Yeah.
And then, as I mentioned, the elderly patients who run out of insulin pump is the way to go. So it's all about micromanaging the blood sugar. That's what you achieve with the pump. You micromanage the blood sugar hour per hour.
How close are we getting to having a pump that is almost like an artificial pancreas, if you will?
We are pretty much there. We're almost there. The only part that we haven't mastered, all the experts haven't mastered, is about your meals, because the pump doesn't know when you're eating. And as I mentioned, these other hormones like the GLP-1s that we are using in shots weekly, these hormones help to slow down the absorption of sugar. They help to control on the liver to release the insulin. They help to slow down on the glucagon. Well, insulin doesn't do all that. So that's the only reason why these pumps cannot take care of the mealtime blood sugar unless you put the information in there. But other than that, we're pretty close. So the three main companies.
Let me just ask you this: how close are we to a pump that is almost like in a car we used to have manual transmissions, and now everything's automatic, right? How close are we to a pump?
Except the meals, we're pretty much there. With the caveat of the meals might be difficult for the pump to control the meal time. But we have systems now. There's 3 companies out there that have systems in which you have a pump and you have a sensor. And the sensor tells the pump what the blood sugar is doing. And there's an algorithm in the pump. And the pump will go up and down based on the blood sugar on the needs. These pumps automatically go up, and this is happening per minute. They automatically give you more insulin when the blood sugar is trying to go up. When you start going down, they slow down. When you start going down too fast or too much, the pump will stop.
Yeah.
And not restart until the blood sugar starts coming back. So it's pretty much a complete, it's called hybrid closed loop.
Yeah.
And it's called hybrid closed loop because of the fact that they want you to enter the meals. That's what makes it hybrid. They want you to enter the meals. And the other one is, being that we are humans, and the other one is liability and all that, you have to have some control. You have to be able to stop the pump whenever you want to.
Sure.
In case anything happening. But they have the beauty that people now, and I have several patients with those pumps, they have the beauty that now patients can go to bed and they don't have to worry about they will be going too low in the middle of the night. Because if they're going low, the pump will stop. And if they're going too low, the pump will not only stop, will also sound alarms and try to wake you up. So you find out why is it that you continue to go low. There's something happen here.
Yeah.
And during the daytime, when you go and play golf and do activities, you don't have to worry about going too low because the pump will stop.
Okay.
On the same token, when blood sugar starts going up and you didn't quite eat, but it's going up for different reasons, then the pump will go up on the insulin production, the insulin delivery.
That's great.
So we have 3 main companies, and I'm not going to favor any companies. But we have the Tandem company, we have the Omnipod, and we have the Medtronics, the MiniMed. And all of them are advancing at a very rapid rate. All of them this year are putting upgrades on the algorithms and changing the model on the pump and getting better algorithms, getting better micromanagement. They are now coming up with the Bluetooth technology, and now they're going to link with your phone, and you can also see this remotely if you have a minor, a child, and this child is 3 years of age, and you can have it remotely and look at the blood sugar and pretty much control the pump remotely. So the kid could be somewhere else playing, and you can have control and monitor what's going on and adjust.
Cool stuff.
So we have it is almost completely automatic nowadays. It is amazing. We have several patients on those pumps now, and I will tell you that pretty much all of them, with the exception of one patient that was used to micromanage sugars, which he's so good that the pump is not really making a big difference because he was so good. But most of them, they love this pump. They just love this pump technology. It is amazing. It's a game changer for these people.
Yeah, sounds like it. And you have the diabetes center is right there in your office. So you probably work with those folks at the diabetes center, kind of co-managing this pump stuff. Is that right?
Yes, we created, when I came to this town, again, 28 years ago, we didn't have a diabetes center. And so I asked about it, and we started working on that. And it took us a couple of years, and we created the diabetes center. So we've been up and running for 2 decades now. And on the diabetes center, they can manage the pumps. For people who are not comfortable with the pump, you can just send the patient and let them handle just about everything about the pump, and they give you feedback. They also manage all the rest of the patients. So from education on diet and behavior modification and exercise to the medications and to the pump management. So we have nurses, dietitians, diabetic educators, and they take care of that. It is in the same office that I'm at downtown.
Yeah.
Like I said, we've been up and running for 2 decades now. Right now it's difficult with the COVID-19. We're all having a tough time through this, but we're getting through this.
Yeah.
And just to give you an idea, because we have many providers who are not comfortable with insulin pumps.
Right.
To give you an idea, I believe we have over 250 patients on pumps in this small area, which is a lot of patients for this.
That's
size
a lot, yeah.
I will tell you that about 6 years ago, give or take, I might be off by a year, about 6 years ago from one of the companies, they came here and they said at that time that per county and all that, we were the biggest pump usage practice in the area, in the whole Northwest Illinois, including Iowa.
Okay.
So we have had many patients on pumps, and we have many years of experience working with pumps.
Yeah. Great. There's a question that popped up. How can I go about checking my own blood sugar level at home?
Okay, so the traditional system is to have a glucose monitor, and you poke your finger and you get your blood sugar, and there's multiple brand names of those monitors out there. Pretty much all of them have memory. All of them can be uploaded to a system, and all of them the information can be shared with your provider. And now we have the continuous glucose monitoring devices, which is most of those are small and the size of a quarter. And you put it on your body, you put it on your shoulder and on your arm up here, and that communicates if it's a pump with a pump. But it can also communicate to either a device or to your phone, and it gives you constant blood sugar readings. Some of those you calibrate, some of those you don't have to calibrate. This year, most companies came with upgrades and all these sensors. You typically keep this sensor for about 10 days or so, and then you just throw it away. When you finish, you throw it away. But it gives you minute-by-minute blood sugars, and it works great.
Yeah. I see another question from one of our viewers. How does COVID-19 affect people with diabetes?
I have to smile at this one because, like everybody else, there's only so much we know about this COVID-19. And I will put it the other way around. We'll say how diabetes affects your risk of COVID-19, of how sick you get if you get COVID-19. Diabetes out of control affects your immune system, and the immune system is how you fight diabetes. Now, about the COVID-19 affecting your blood sugar, when you are sick and if your body is responding properly, you're going to burn more calories. Your body is generating more calories, and that's how you get the fever. We have chemicals on the body, prostaglandins, that make you burn more fuel. And it could affect your blood sugar by going down, but it could also affect it by going up because it can get into the pancreas too, and your pancreas production might be affected.
Yeah.
Not to mention if you cannot eat much because you're getting upset stomach, which is common with this, you may not be taking medications and the diet will change. So it will definitely affect you.
So obviously diabetes affects your immune system, and that can have an impact on the COVID infection. I haven't read anything about this. We're so early into the COVID in many ways from a science standpoint. How about if your diabetes is well controlled versus not well controlled in terms of how COVID would affect you and if you were infected with it and your immune system's response?
If you are well controlled, you should not be immunocompromised. If you get a hemoglobin A1C that is approaching, it's very hard to get into the normal levels for hemoglobin A1C. But if you have a hemoglobin A1C that is approaching normal levels, your body, chemically speaking, is normal. And you can fight infections. On the other hand, if your hemoglobin A1C is not good, then your body cannot fight infections. And you have to remember that the blood sugar that we look at we're looking at the sugar in the blood, but the cells are starving. Every cell in the body is starving for sugar. That's why it's high in the blood, because it's not penetrating into the cells. Right. So your white blood cells that are fighting for you are not getting enough sugar. Your whole body, except the brain, is not getting enough sugar into the cells. And so then your body's compromised. So it makes a big difference.
Yeah. Good. Okay, here's one. I've been on Metformin for 23 years. Is it possible to ever get resistant to the drug? Lately, I feel that it hasn't been working as well, and I've had no lifestyle changes.
The metformin works by making your body sensitive to the insulin you already have. So nobody should get resistant to metformin, but it's the insulin that you already have, the production of insulin you already have is going down, then the metformin is not going to work so well because
So
you
it's going to
just
seem
don't
like
have enough insulin.
Yeah.
So it's not the metformin not working. So if somebody's on metformin and it's not working well, it's because you have gotten to a point that you need to move on and add more medications. Because your insulin production is most likely down enough that is not enough for the sensitivity increase you got with the metformin. So it's not the
or would there be an opportunity, Angel, if they were to, let's just say that they were a little bit overweight, if they potentially could reset some of that or not by taking off 5% of their body weight.
Yes, definitely. 5 to 7% of weight loss will make a difference on
it may make that metformin seem to work better.
Yes.
Yeah.
But if somebody's on metformin and your diabetes you're not responding now because it's been 20 years, like this example, it's not the metformin, it's the diabetes. It's about being diabetic for 20 years.
Yeah.
We've been diabetic for 20 years.
Yeah. Good question. And speaking about time, this is, I think, time-wise, is probably towards the end of what we can ask question-wise. But speaking of time, Angel, how does diabetes cause the damage it causes in your body over time?
So diabetes, as we know, it's a syndrome, especially type 2 diabetes, in which you have diabetes, you have high cholesterol, you tend to have high blood pressure, usually it's together with obesity. So like I mentioned before, every cell of your body is starving for sugar. And your body many of those cells have to find alternative ways to create energy by burning fats and burning proteins. So it affects your whole body. So it takes a toll first on the vascular system. You get atherosclerosis. It affects your coronary arteries over time. It also affects your kidneys. So your kidney function keeps declining because of the same vascular problem.
Yeah, because your kidneys have blood vessels.
Yes, the kidneys are blood vessels, and the blood vessels in the kidneys take a toll. Also, the filtration system, as I mentioned, we have a system that absorbs the sugar as it's going through. The whole system gets out of control. Also affects your nerves on the body because even though our brain doesn't need insulin to function, the repairing of the nerves on the body need the insulin for all the metabolism there. So it affects mostly your peripheral nerves, and people start having burning feet and tingling sensation of the feet. Affects your vessels to your extremities, so people can end up having toe amputations because of low blood flow. Affects the blood vessels in your eyes, so affects the retina, and then you lose your vision from that. It affects the blood vessels in your brain, and increases the risk of strokes, increases the risk of dementia. So it affects every part of your body, and it takes time to do it. But if it's not controlled, it will do it.
Yeah, and that's the good news I think that we could end with, is that it doesn't have to be that way. Correct. If you can control it.
Yes, and again, we have time. This process is very slow. So if you tackle your diabetes early and you get aggressive about controlling your diabetes and follow with the hemoglobin A1C, you can delay or, in theory, completely stop this process. And then you don't have to worry about that. Yeah. And having said that, I would like to mention here about pre-diabetes. Every time we discover a diabetic, it means that we miss a pre-diabetic. Every time we discover a type 2 diabetic, we miss the window of being pre-diabetic. So if we could do a better job of finding pre-diabetics and getting aggressive at the beginning, we would have less diabetics. Something that I read, out of the pre-diabetic patients out there, 83% of them don't even know they have pre-diabetes. So we're only finding and treating the tip of the iceberg when it comes to pre-diabetes. Yeah. And again, if we start at that point, then we're going to postpone all these vascular damages.
Yeah. Good. We could go on. Dr. Blazquez, with information he has up there in that head of his, we could go on for a long time about this.
Yes, we could. It is my passion, and I enjoy it.
But I wanted our viewers to get at least a taste of the information that you had in your head, and it's been really good to hear about that. and to hear about that information. And just for our viewers, if questions have come to mind after you watch this, you can send that to our website or our Facebook site, and Dr. Blazquez can give some information to our marketing team and give you some more information about that. So thank you, Dr. Blazquez. I knew this would be very informative, and it absolutely came through in that regard. So thank you so much for your time and your work with diabetes here in the community.
Thank you for this opportunity. And to the people out there, just take it seriously. You can make a difference on your life by addressing diabetes. Also, I will say this, do not ignore pre-diabetes. If you can tackle pre-diabetes, do not ignore that pre-diabetes. I see many patients who were told that they were pre-diabetics 3, 4, 5 years ago. And then they show up in my office 5 years later saying, oh, I used to be pre-diabetic and now I'm diabetic. Well, you missed that window.
Yeah.
So don't ignore pre-diabetes also.
Yeah, good. Hey, Dr. Blazquez, thank you. Great having you. And I have a feeling we'll have you back sometime.
Okay, thank you very much. It was a pleasure.
Right,
thank you.
Okay, bye. All right. So, yeah, that was really good to have Dr. Blazquez and get that information. I wanted to, as always, share some information about where we're at in terms of the pandemic here in our community. So, and by the way, if you really want to have a day-to-day kind of information, our website has, oh, here we go. All right, there we go. So there's some local information about what's going on with COVID here in our area. And our hospital website has a number of patients, Whiteside County Health Department information, our visitor policy, information about where you can go to get testing. So there's a lot of great information on our website. Oh, there we go. And that's what you'd pull up. Man, you got Matt and Dana and Rebecca, you guys are so good about this. This is so nice just to chat and then it pops up. So yeah, that's kind of where you can go to our website and get day-to-day information about that. We have, I think we have 30, that was this morning, we had like 33 patients that had COVID in our hospital. So we're managing it, but it's our wave is here. It's definitely happening. And thanks to all our hospital staff for the work that they're doing to kind of keep things going and take good care of people. Both our medical staff as well as the rest of our staff, nursing and others. So thanks to them. I did, in terms of our testing numbers, we've actually hit the 10,141 mark in terms of how many tests we've done since this started. And since this started now, we've had 1,173 positive tests just here at the hospital. So yeah, that, once again, that fits the wave that we're having. What else did I want to share? Oh, one thing that's changing in terms of visitation now. So on the hospital side, on the inpatient side, we're not having visitors come in other than for certain very select circumstances, like a support person for a delivery of a baby and those type of things. So we are going to, starting tomorrow after 5:30 p.m., those main doors at the hospital, we're going to have those not open after that 5:30 period of time, and they'll open back up in the morning at 5 a.m. And so patients will go to the emergency department if they need to get in the hospital. So that's just a way to try to manage things better. And from like Friday at 5:30 p.m. till Monday at 5 a.m., those doors won't be open either. So once again, the emergency department will be your portal if you need to access the hospital or have conversations and those type of things. Just a way to try to kind of control the flow, help with the whole process with our staffing and taking good care of patients and all those kind of things. Anyhow, I want to make sure I don't have any other questions that have popped up that Dana has sent me. Good. Well, hey, as every week, thank you for those of you for listening and sharing this with folks in our community. And I just thankful for the opportunity to share this information. And another question here about, is Sterling really number 2 in the nation for COVID cases? I don't know about number 2 in the nation. I would say that I can't tell you for sure about that. I looked at the New York Times map yesterday, and basically the upper Midwest. So if you look at Wisconsin, northern Illinois, parts of Minnesota, Iowa, are all red, and red meaning like the hottest you can be in terms of COVID. Our numbers, I thought yesterday, we were at like 59 patients per 100,000. And if you look like in northern Wisconsin, I think there were some people that were over 100 per 100,000 population. So I'm not sure, for our listener who asked me that question, if there's some other metric that people are using to determine how hot an area is, but make no mistake about it. We definitely have a hot area here. A lot of the wave is definitely high right now in the Whiteside County, Carroll County, northern Illinois, Winnebago County area. If I remember right, the governor, basically all the counties in the state now are under more mitigation because of the more cases. So it's just a thing going throughout the Midwest. And we are at the hospital doing all we can to take good care of the people that show up, and encourage those outside the community to continue to do all the things you can do to help to keep the case count down, and appreciate everyone and the work that they're doing. We'll get through this. We'll get through it. Okay, other questions? I'll leave a little bit of a moment here for those who might have them. Okay, thank you. Yeah, thank you. I appreciate that. So just some feedback and thanking for what we're doing. I really want to thank our staff. I can't say how many times how thankful I am for the work our staff is doing. They are, it's a very unique time. And here's another question. Do we know if people are being reinfected by COVID-19? Yeah, you read the literature, an occasional case where someone was reinfected where they really feel like they weren't reinfected. But I also read something, I think it was last week, where, and granted, this science behind this, we're going to figure a little bit more about this in the next year or two. But I read something last week where they feel like 90% of us who get COVID still have antibodies 6 months out. So I would say you can never say never. At least 6 months after the infection. But right now it looks like you're probably okay for a few months afterwards. And we're going to have to figure out how many few months afterwards people are going to stay okay. Remembering that antibodies is just one way our body fights infections. And we have T cells, what are called T cells and B cells, which are another form of our immune system to fight off things that want to cause problems in our bodies. So that's the best I can answer that question right now. Other questions? Those are good questions, folks. I appreciate them. Okay, good. Well, if you have other questions, feel free to send those to our website or Facebook page, and we'll try our best to answer those between now and next week. Looking forward to talking with you next week. We'll have a broadcast. I think what we're planning right now is to talk to our pain management folks, but of course we'll be talking about pandemic, COVID, and those type of things as well as we go forward. Where are the cases coming from? Restaurants, bars, family parties? Do you suggest we cancel family gatherings? The cases are coming from a lot of different places. The ones that were just listed there, long-term care facilities, group homes. It's just, this is a virus that gets, it's a lot of different places. So yeah, I would just encourage folks to be reasonable. The governor, I think, is on the right track with, trying to limit things to 10 or less by and large right now. So, I wouldn't say not to have family gatherings, but what I would say is, try to, as best you can, for the folks who are going to be showing up, I think it'd be prudent just to say, hey, have you been wearing masks where you've been at lately? And if you've been trying to, as best you can, keep out of harm's way. And I think that's important for those get-togethers. And I would not be in favor of gatherings that are, you're like a big gathering, a wedding, or, dozens of people showing up for a gathering, because you just increase your odds in those type of situations of someone having it. And if they do, then that's when we start to see more cases begin to show up. So we have to live our lives, but at the same time, we just have to be prudent about that. And I think what the governor is throwing out there is pretty reasonable stuff. Understanding that even doing reasonable things, sometimes you're going to have some folks that are going to get exposed. But it would really reduce it if we kept away from some of those real obvious big things, and that would be helpful, I think, in terms of the number of cases that we have in the area. That being so the question is, if you're both masked, can you not socially distance too? Or if you're both masked and social distance too? Yeah, I think you're really reducing your risk if you're masked and socially distanced. Getting together with folks in that type of scenario, that's the best case scenario. Your risk goes way down in those situations. As you can never say never. And, we take on risk getting up in the morning and going about things. So if you can socially distance and wear a mask, that would be really helpful. With the indoors component of things right now, even with socially distancing and masking, there's always that concern. But boy, you're way ahead of the game if you can do that. That's another good question. Hey, I've gone pretty long today. And I appreciate for those of you who have stuck with me this whole time. And thanks, Dr. Blazquez, again. Thanks you for your great questions. Look forward to talking with you next week. And until then, please stay safe. And we'll be back noon next Thursday. Thanks. Bye.